I'd like to introduce Gina and Amanda, and you guys can take it from here. Thank you so much for presenting.
Well, thanks for having us. So I'm Dr. Amanda Ihlenfeld. I am a psychologist at Melrose Center. I have been at Melrose Center for almost 8 years. No, it has been 8 years, but I think it's been the last three, maybe, that 3 or 4 that I've been with Gina partnered and really working with our diabetes population.
Yeah, and I'm Gina Patnoe. I'm a nurse and diabetes educator. I've been at Melrose with our diabetes program since, let's see, 4 years now. And I also work part-time just for general diabetes education in the health partner system. Yeah.
So I was going to start by talking a little bit about Melrose Center, just in case people are not familiar with who we are or what we do. Melrose Center has been around in different forms for over 35 years, and we exclusively do care for people with eating disorders. So what that means is if somebody has a diagnosis of an eating disorder, we are able to treat them. Now, the people that we see do not just have that diagnosis. We have people who have a lot of other like medical complications. We have people with other mental health diagnoses. But the main thing that we do treat is eating disorders. Age range for who we treat tends to be around 10 years old and up. I think I've had patients who have been in mid to late 70s, so it really does run the gamut. We have 5 locations in the Twin Cities. Our main flagship location, which is the picture that you see here, is in St. Louis Park. But we also have outpatient clinics that are in Burnsville, Maple Grove, St. Paul, and Woodbury. So those are other places people can also do outpatient programming. At our St. Louis Park location, we have the ability to see people in different levels of care, and we'll talk about that. We do have an inpatient residential unit that can house up to 39 people currently. And a little bit to know about us is that we have had our diabetes specific treatment track since 2005. We have treated people who have had the dual diagnosis of an eating disorder and diabetes, specifically type 1, but we also see a lot of type 2. And we partner with Park-Nicollet Endocrinology, which means that anybody who comes and sees us, especially for inpatient treatment, if they are needing that level of care, will be able to meet with an endocrinologist during their stay with us throughout the course of treatment. So typically like once every week or two, they will be seeing an endocrinologist that we work with. We like to talk about our program, and so we're really glad that we're here and we get to talk about this because, as Brad was saying, if people were on, there are not a lot of places that really talk about this and also that treat it. We're one of 8 facilities in the US that accepts patients with type 1 and eating disorders. And so there's a really big need for this, but unfortunately not a lot of care that people can get if they're struggling in this way. And so we're really proud of the work that we do. Our program does include different levels of care. Our highest level of care is intensive residential. That is for people who tend to be medically unstable and needing more acute care. We have a residential program as well that is for people who are still needing to have more 24-hour care, but they are more medically stable. Our partial hospitalization program is every day, like Monday through Friday type program that runs 8 hours a day. We have an intensive outpatient that is 2 days per week. The majority of our patients are able to stay in our outpatient level of care, though. And so I think that's something that's really cool to note, that 85% of our patients really only need an outpatient level of care. And so we are able to provide that. And that's a really great way to meet people where they're at, especially especially if they are just learning that they are struggling with an eating disorder. Sometimes it's hard to think about all the stuff that goes along with that. And so it can be to our benefit to be able to see them in an outpatient setting and then assess the need for any other additional or more intensive care. So to talk a little bit about eating disorders that we see, we have the 6 that are listed here, and these are the ones that we are primarily seeing. They are anorexia nervosa, atypical anorexia, bulimia nervosa, binge eating disorder, OSFED, which is our most common diagnosis, and then ARFID, which is avoidant restrictive food intake disorder. I'm not going to kind of bore you guys with going into all of the specific diagnostic criteria of these. We'll talk a little bit about symptoms that can come up in one of the next slides. But what I do want people to know is that a lot of times we see diagnoses that fall into this OSFED category, and many of our patients who have type 1 and an eating disorder, and even type 2, can sometimes fall into this OSFED category because of the way the criteria is laid out so specifically for some of the other ones. So this OSFED category tends to be the one where we know there's something going on. There is clearly eating disorder behaviors that are happening and people are struggling, and maybe some of the symptoms they're using don't nicely fall into some of these other categories. And so that is the one that helps us to be able to put a name to things so we can start working treatment plans and moving forward with recovery.
And I'll just add, Amanda, too, I think in research, we see a big overlap in type 2 diabetes and binge eating disorder. But I think we also see a lot of binge eating disorder and type 1 diabetes as well. So certainly any of these diagnoses could show up in any type of diabetes with that overlap.
Absolutely. Thank you.
Yeah. And just sorry, one other note with the atypical anorexia in the eating disorder world, we don't love the word atypical because it really is all the same diagnostic criteria as anorexia nervosa, just with someone whose BMI is technically over that 25 or over that normal level. But I think with GLP-1s, I know, again, those are more indicated with type 2. We're seeing a lot of people with type 1 on them as well. I think more and more we're seeing people having restrictive eating disorders with GLP-1s who maybe started in a larger body. So something, if anyone wants to talk through that or things they've seen with that, I know that's something we're seeing a lot more of too.
So some of the symptoms that we oftentimes see with eating disorders, in this blue box is a list of them, and we can kind of see these in any different combination. So I like to say eating disorders are kind of like snowflakes. No eating disorder is going to look exactly the same, and so you can have different symptoms that come up even in the same person at different times, like as they're struggling with their eating disorder. So oftentimes some of the more common ones we're seeing are restriction. That can be restriction alone of food, or it can be accompanied with other symptoms like purging or even binging and purging. We will occasionally see binging alone, purging, where if somebody might do self-induced vomiting or laxative use or abuse, diuretic use or abuse. Compulsive exercise is something that we see frequently also as a way to compensate for eating if somebody is struggling with guilt or shame around some of the eating that they've been doing for whatever reason. And so these are some of the ones that we see most common. The part that can be added with this is if somebody has type 1 diabetes, for example, or they might also be withholding insulin. That could be another example of a symptom that they are struggling with. And what I want to make clear is that this is what we typically call, well, we don't call it this, but like popular like media calls it diabulimia, if you've ever heard that term. And so that is usually what we would say, or people are referring to if they are talking about somebody withholding insulin as a way to lose weight or manage their weight. That being said, somebody with a diagnosis of diabetes and an eating disorder diagnosis doesn't actually have to be doing anything with their insulin to be struggling with these two together. And I think that's really important because sometimes people will say, well, I'm taking my insulin as prescribed, I'm doing all of my diabetes cares, and so I don't have a problem. That might be true, that they're doing all of these things, and the eating disorder can still be really powerful and it can still be impacting how they are managing their diabetes. And so just know that we're not just looking for insulin omission as something that tells us if they're struggling. Some general information, just to kind of wrap our heads around what this is what the research is telling us about this, is that up to 40% of young women with type 1 diabetes intentionally reduce or omit insulin to control weight. So something to put out there is that this is something that we are seeing frequently. And I think that it's good to know this because these are things that people aren't always talking about. And so there's probably a much bigger prevalence of this than we might even notice or realize. So ordered eating behaviors as well, we are seeing in 21% of adolescents with type 1 diabetes. And so those are the numbers that we're looking at. And so what we're finding is that these things they're out there and you're probably seeing them or hearing about them, or they may be more often than you might initially think.
I got a little question, Amanda, if that's okay. Just to kind of clarify that 40% of women, does that include just women that are trying to eat lower carb, that maybe you want to reduce your insulin levels because they know that higher amounts of insulin and higher amounts of carbs might lead to that?
No, so this study was referring specifically to young women that admitted like taking less than what their prescribed dose would have been. To lose weight or control weight, not just eating lower carb. Yeah. Mm-hmm. And this, you can see 2012, we need updated research. I'd be curious with, AID systems and just, even more CGM use. Hope, when you have that data and that accountability, is this harder? But I also think this is probably like subclinical eating disorder symptoms too, maybe just, one or two times on occasion taking less than they're supposed to. So it might not be a full clinical eating disorder diagnosis too.
Gotcha. Sorry. And I'm probably a little bit skeptical because we have so many like vendors come in nowadays and like, this medication does this and this and that. And you're like, wait, that doesn't make sense. So I know you guys are part of the center and you're more, it's just like impulse. I can control myself, but I wanted to make sure that like, okay, it wasn't just that they were, reducing it because they're taking in reduced carbs or something like that.
Right. No, great question. And because I know that it's shocking, right? It's a large proportion. Yeah. Mm-hmm.
Thank you.
A great question. So thank you for asking that, just to clarify, because it is, it's much more out there than people think. So when we're talking about eating disorders in general, I think one thing that's really important to do is to understand that eating disorder thoughts are different than what might seem logical thinking. Okay, this is where it can get really tricky. So you might have somebody who is going to their provider to work with their endocrinologist on how to best manage diabetes and do all of the things. And if somebody is also struggling with an eating disorder, there are ways in which they might approach things or think about them that don't seem to make logical sense. And oftentimes it doesn't, because they are making decisions based more on emotion-based reasoning about how they feel about their bodies or how they are feeling about their weight or specific numbers. And so noting that if you are talking to somebody that is, excuse me, struggling with an eating disorder in addition to diabetes, they're oftentimes going to present with some very inflexible and rigid rules. So an example would be, we might think of times when we eat differently, based on what our blood sugars are, or where the arrow is pointing on our CGM, that type of thing. But we can also be flexible with that. So if there is like a specific like special event or occasion, that type of thing, there might be some flexibility there. Whereas somebody who's struggling with an eating disorder really will struggle with having any sort of flexibility around the rules they have established for their eating. And every eating disorder does have its own rules. So there are some eating disorders that are okay with, eating a certain amount of maybe carbohydrates, right? Whereas others will say it has to be under this level. So it can really vary. So part of it is asking each person, or kind of trying to get a sense from each person, if you are, if you know somebody who's struggling in this way, or you yourself are struggling this way, it can be helpful to know what the rules are that are guiding how somebody might be interacting with food. It might be also important to know that there can be rules around food, but there can also be rules around diabetes management practices. So this could be levels or blood sugar numbers that they are willing to give insulin at versus when they will omit insulin. And those rules can be very strict as well. And so trying to understand those things really does require kind of a team approach, somebody who understands eating disorders, but also diabetes management, because some of the rules really can contradict what would be recommended medically for the person to manage their diabetes. When somebody does break one of these rules, it can oftentimes cause a lot of intense guilt and shame. And so they might then compensate with another behavior. And so this is part of a cycle that people can get into when it comes to how their eating disorder and diabetes management can get into kind of a dance where they kind of go back and forth and really get stuck in patterns that kind of amp up safety issues for treatment and all of those types of things. It's important to also know, and that we know, if somebody is doing something that is because it's being driven by their eating disorder, even if it doesn't make sense for their diabetes management, we know that people might be in a place where the voice of the eating disorder in their head becomes so loud and unrelenting that even if they did want to do what is being recommended by their providers in terms of insulin use or eating and all of those guidelines, sometimes they know that if they do those things, the eating disorder is going to make things so difficult for them that it's almost easier to listen to the eating disorder. And so I want to make sure that people understand that typically if somebody is doing a behavior that is unhelpful, they oftentimes know that. It's just that they are struggling so much with the backlash that they get from the eating disorder that it's easier to listen to that than it is to actually challenge it and do what maybe providers or other loved ones are trying to encourage them to do.
Question.
Mm-hmm.
I have an eating disorder. After 6 o'clock at night, after my meal, about an hour later, I crave carbohydrates. And most days I cannot stop. I'll have 2 pieces of string cheese, and then during a commercial or something, then I'm up looking for something else. I've tried carrots, I've tried celery, anything crunchy, something chewy, and it just gets back to the fact that I'm ending up with carbohydrates. Now, is that a mental disorder or is that a physical disorder of my type 1 diabetic? Is there a way to tell?
So there could be both factors. Um, I'll talk about the mental part of
Okay.
it, and then Gina, maybe you can speak more to maybe some of the other pieces of it, like physiologically. One of the ways that we talk about eating disorders is that people tend to struggle when things are restricted. So if we say something's off limits to ourselves, like I shouldn't be eating this is bad, right? People actually tend to want it more, right? I have a 7-year-old. If I tell her not to do something, that is the one thing she wants to do. It's like whatever I told her not to touch or do, it's like it starts glowing and she's drawn to it, right? And so we kind of have that mentality of if something is off limits, we want it more. And then when we have it, oftentimes people will say, I actually eat more of it than I would have if I could have had it like normally, without any like guilt or shame around it, because it's a bad thing and I'm not going to do that again, right? Because I know I'm going to go restricted again. So I want to have more of it. And so there can be that mental aspect of when we tell ourselves that we can't have carbs or we're trying to restrict them in some way, it can actually cause the reverse.
Yeah. And so yeah, completely agree. Oh, sorry, go ahead.
Well, it only happens in the evening when I'm sitting down relaxed. So that's going to be more of a psychological deal to where my mind drifts over to like, okay, I'm relaxed now. What do I do when I'm relaxed? Okay, hand them out, hand them out, hand them out. As a former smoker, I understand. Hand them out, hand them out, hand them out. Now, if I can quit smoking and quit drinking, I should be able to quit hand them out psychologically. But that's what kind of tells me that maybe it's not all mental, that maybe it's part physical, and that my body is craving the carbohydrates that it used to have for 50 years. Is that reasonable to assume? And if it is, any ideas how I can plug my mouth?
Gina, did you want to add? Because I think the other piece I would add before Gina, I'm going to throw this back to you, but is that sometimes you're right. I think there's also an environmental piece of this as well. We can really be triggered in a way to do certain behaviors or have certain like thought patterns with certain like stimuli around us. So maybe it's the act of sitting in the chair in the evening, right? Or whatever it might be, but that's the thing that reminds us, oh, this is what I want to do, and this would make it feel even better.
Sure, kind of like going to a movie theater and always buying popcorn.
Exactly. Yeah. And I think too, trying to speak generally about it, exploring, hey, are there times earlier in the day where carbohydrates might be more restricted? Because even if at that moment, yeah, you just had dinner an hour ago, if your brain is still feeling inhibited from not getting sufficient carbohydrate earlier in the day, that still could make you physiologically say, hey, I need some carbohydrates, or I really want some carbohydrates. So some of it might be, actually including more carbohydrates that throughout the day might be helpful. And we know both, one question too would be, hey, where are blood sugars at that time? Because that's one part where it's actually one of the next things we'll talk about too, where the intersection of an eating disorder with diabetes is so hard because fluctuations in blood sugar levels can impact your hunger and fullness. And so if your blood sugar tends to be elevated after dinner, this can vary from person to person, but that can sometimes actually kind of trick your brain and say, hey, even though there's sugar in the blood, your cells need sugar. And they're saying, hey, give me more food, give me more sugar. And that can actually signal some of those hunger signals, even though we want it just, that random amount of insulin to bring the sugar into the cells. So that's where Amanda was saying sometimes physiologically that can play in too.
Thank you.
Yeah, thanks for asking. It's a great question.
Yeah, Brad.
Thank you. And I just kind of wanted to test that hypothesis too, because Michael was saying that I was kind of like, kind of cracked a smile because I'm like, well, what person doesn't have that a little bit? When is there not temptation to have sweets and you get that instant gratification and, that you feel a little bit better. So I'm kind of wondering, just the times it's tough to find that gray area of when it's kind of a human condition where there's always temptation for a lot of different things out there. And, all of a sudden someone kind of gives themselves a diagnosis and they say, well, it's this that's taking the wheel. I'm diagnosed with this. Isn't there like a danger, a kind of rabbit hole to all of a sudden be like, I'm diagnosed now, and now I have this versus, you know, kind of be like, you're not alone. We all have this kind of
Mhm.
issue. We're working on it. We're getting better. We're having it maybe one day less per week or something like that. I don't know. I just find that such a fine edge. Maybe I'm just making a statement.
Right. Well, and
Yeah.
I agree with that. I think yeah, that fits for what we talk about oftentimes with people who come into the office is that really the big part of it is how does this impact your life? Right. There are people who will engage in behaviors like this, where, yeah, it's in the evening, you keep wanting that next thing to eat. And they can do that and then kind of move on to the next thing after, they get what they're kind of wanting. But we're talking about with patients that we see, oftentimes this is something this is what they're thinking about 24/7. They are thinking about, what am I going to eat next? Like, when did I last eat? Should I eat that? Oh, I'm going to feel bad if I eat that. How do I hide if I ate that? Right? I mean, it's this constant chatter that is happening, and it's really interfering with their ability to kind of get through their day and have a good quality of life. And so I think that in general, it is really helpful to kind of know our own stuff, right? And be able to talk about it openly, because oftentimes we feel less lonely, and when there's more validation, hey, I'm not the only one, that can be so helpful to reduce shame and stigma. And if somebody is struggling in a way where they're saying, I'm having a lot of consequences from this, that's when it kind of tips over into that other space.
Mm-hmm. Yeah, I'll just second that. I think it's that gray area where it kind of crosses the line is just that amount of distress that someone's experiencing, and it could be how it's impacting their diabetes, or if they're compensating the next day. So maybe someone is really struggling with night eating or overeating, and then the next day they have so much guilt that they don't eat for several hours, or they exercise extra, right? So these behaviors that the eating disorder says they have to do to try to compensate.
And it's
Is
just
that
tough
helpful?
because sometimes those are great strategies, with all of a sudden, oh, I'm gonna cool it without eating, or I'm gonna exercise a little bit to get my blood sugar down. Maybe that insulin's not absorbing. So that's such a tough thing to bring up because they're saying, hey, that's, sometimes beneficial, sometimes not. It's tough finding that. Anyways,
Yeah. No, I think it is, especially when we talk about rules. Because it's in some ways that's what managing type 1 is, right? It's like having these different behaviors and ways that you manage it. So I think a lot of it is, hey, are you able to be flexible? And, like Amanda said, if you have a special event, or, normally you really eat a low carb breakfast because that's easier for you to manage blood sugars the rest of the day. But you could go out and eat a larger breakfast with friends and it'd be okay, so kind of that ability to be flexible. But it's such a tricky thing to dice out. What's the eating disorder? What's diabetes management?
gotcha. Sorry for derailing that. Keep going.
Well,
No,
I
this
think
is
what you're
great.
asking about is the crux of what we're talking about and
Yes.
how it is such a fine line. So I'm glad that you asked that.
Mm-hmm.
So this slide really does talk about some of the challenges that we see with the intersection between eating disorders and diabetes. When we talk about diabetes management, there is such a focus on numbers. There can be focuses on blood sugars, right? Time in range, A1Cs. A lot of times when we are talking to people, they will say one of their first experiences when they were diagnosed, they were taught to, stay away from carbs or eat as low carb as they can, right? And so then that there's already a discussion that comes up with about restriction, essentially, is what they're talking about or being told, without maybe a lot of guidance about what that really would look like in a way to have a healthy relationship with food and manage diabetes. And so when we see these two things interacting, it can be challenging because You have these rules you're trying to follow that are very good rules, right? If you're just managing diabetes, right? If you were managing that in a silo, that would be great. And for somebody who's struggling with an eating disorder, sometimes these rules become a hyper focus or fixation that becomes very rigid and inflexible. And it really does become this thing that they are not able to, they aren't able to veer from without, like we talked about, that guilt or that shame or that feeling of, I have to do something about this. This is terrible. This is bad. I did something wrong. It was unhealthy, right? And so they can't get away from that. And so they have to do something about it. That's where the eating disorder really guides a lot of this stuff. And one of the things that I've heard patients with this dual diagnosis say frequently is that it's especially cruel to have both of them, because with an eating disorder, they are already very focused on their bodies. And then sometimes if they've been diagnosed maybe later in life, now they are having to pay extra attention to their bodies in ways that they don't want to, or ways that make it harder for them to be accepting of their bodies. And so it really does make body awareness and body image a lot worse for patients when they're having to interact with their body in so many different ways throughout the day.
And I'll just add too with the hunger and satiety disruptions. I think, my goal for all humans, it would be to be able to eat intuitively, right? Eat when you're hungry, stop eating when you're full, trust and listen to your body. But diabetes, especially type 1, makes that really hard. If your whole, since your diagnosis, you've taken an injection or a bolus, and then you have to eat whatever you bolused for, even if you get full, or you have to eat when you're low, even though you just ate, recently. Or I often, anytime I work with someone before 2000, or who was diagnosed with type 1 before 2000, who was on NPH and R, they talk about how challenging that was to have to eat at these fixed times, no matter what their hunger and fullness signals are. So just to validate, just how challenging this can be, and what the research tells us why this shows up more.
So this is kind of a built-in check-in point. We just wanted to put out some questions to think about. And you can think about this kind of in your own head. You can share some of that in the chat or out loud. But just to think about the messaging that has come to you about food, carbs, your body, all of these things that really do intersect with both struggles with eating disorders possibly, and or diabetes management. So kind of curious if anybody is willing to share.
I would love to share, actually.
Yeah.
It impacts my relationship with my body in that I feel like it's been taken over by some corrupt warlord that just wants to destroy me slowly and rob me of the joys of life. And I always feel like I'm at war with my body. And in regards to food, it's like one mistake can kill you. And there's times, honestly, I look at like sugary stuff, starchy stuff, and think if you keep doing that, you're gonna lose a limb, your kidneys are gonna shut down, you're gonna go blind, I've never had issues with body image, but it's more like I don't know if it's genuine concern for my health or if it's anything problematic, but I choose to follow like a more low carb keto diet because my blood sugars are in a straight line now and I feel way better. Because honestly, I had an addiction to processed foods for so many years. It was a binge eating disorder because I just didn't care about managing diabetes. I just take a random dose of insulin and eat. I just kicked the addiction to processed foods, and now to prevent me from relapsing on the junk food that almost killed me from severe highs and lows, I imagine that warning labels on tobacco products. Warning, this will induce diabetes complications. This will make you lose your eyesight. This will make your kidneys shut down, and etc. I don't know if that's a good thing or bad thing considering my history with addictions and processed foods.
I think that can be really individual for the person. And Gina, I don't know if you want to add anything else to this, but I mean, I've worked with some people who they've described when they were diagnosed originally, it was a lot of scare tactics about if you don't have your diabetes in range, right? These are all of the complications. And they felt so overwhelmed by some of those things that they kind of said, why bother trying? I'm not going to be able to make this perfect. And that's what they're telling me I need to do. And so I might as well just kind of do what I want. Right. And so the scary things became so overwhelming that they kind of almost shut down. And, for other people, those can be the reminders that are like, okay, this is what I'm working towards. I'm working to avoid this. So yeah, that one becomes really individual.
Another thing is too, my mom was acting from, I think, a very fractured emotional compass. And it felt like she was always watching my Dexcom, and if it went high, she always thought I ate something, even when I
Mm-hmm.
didn't. And she would ground me for lying. And a few times she even withheld insulin from me until I confessed what I ate when I didn't eat anything.
Mm-hmm. Yeah. And I think what you're talking about really highlights the there is so much. I mean, kind of like you said, I mean, there is a lot of fear that's associated with this. And so the challenge of managing that fear, whether it's coming from, the diabetes management standpoint, or sometimes we oftentimes see a very similar fear in our patients who struggle with eating disorders as well. Of this fear of this is what's going to happen. It's going to be the worst case scenario. And so I have to control this, or I have to be the one kind of in charge of some of these things. And, this is not for you. I'm kind of speaking more generally because I don't know you in particular, but I think this is how, some of these things start to impact that relationship with food. And it also starts to impact the relationship we have with our bodies. Can I trust my body? Well, I can't, right? I don't know what it's going to do. I don't know how it's going to respond. And that can be really challenging then to know, to feel comfortable trusting it in any way. So when we introduce new foods or different, things, like it becomes it feels very life and death and very scary. I appreciate you sharing your story because I mean, this stuff is so hard to talk about. And it's, this is what we talk about when we say how this stuff can be kind of life encompassing, and the importance of having or being able to
And
find people or that you can trust, or that you can work with to help manage some of the stuff that comes up around this.
Mm-hmm.
Thank you. There's a comment or maybe something in chat. So somebody had mentioned too, and thank you for this. Trying to read this comment. Let's see. One of the things that this person mentioned is also something we hear very frequently is when they go to meet with their endocrinologist, one of the first things that is discussed is about weight, and having weight be the central focus of things, and how challenging this can be on different levels. One of them is you can be doing all the things, right? You can be doing all the things to manage diabetes, and that doesn't necessarily mean your body is going to respond to those things in terms of what weight does, and also how this kind of pits a person who's already struggling with the relationship with their body against their body even more, and trying to manage this number, yet again, another number. And so I hear this frequently. And so I don't know if anybody wants to share about that or anything anybody else wants to add, but that can be really, really frustrating about how weight can become a focus, more so than what somebody feels like they're doing for their diabetes management.
Mm-hmm.
So I'll share a little bit. So my endocrinologist actually is constantly telling me that I'm doing well with my hemoglobin A1C and my blood sugars, but I keep saying I keep gaining weight. I want some help with that. And um, their response is, you're just doing fine. You're worrying too much about your weight. And my BMI is over 25. And so, Lyman, when you were talking about processed foods, and by the way, thank you so much for sharing your story. I can relate to it on so many levels. I've had type 1 diabetes. I'm 60, going on 63. I got it when I was 15, but um, I still feel like I eat processed foods, which I don't like to eat, but my sugar keeps constantly going low. And I also have gastroparesis, which makes it
Mm.
difficult for my food to be digested correctly. So I'm dealing with that too. But I wish I could get other information or ways in which that I could. I don't like being the weight that I'm at. And even though my doctors will say, oh, you're fine, maybe from their perspective, I am fine. But from a personal level, I kind of body shame myself maybe, and I tell myself, don't do that because, but you know, it's difficult. You know, diabetes is it's a constant 24/7. It's like a job, a full-time job in addition to life. So, anyways,
Absolutely.
that's what I
Mm.
Right.
have to share.
Absolutely. Thank you for sharing that. It reminds me of many conversations I've had with individuals who have said that for so long there has been such a focus on BMI and those types of things, almost to the point where the story you're sharing is actually different than the one I typically hear. Typically, I will hear people say that their numbers are in range, or their A1C is looking great, and their doctor is still telling them like, oh, here's this problem with your BMI. I'm hearing yours is almost, kind of the opposite, just in terms of how you're feeling and really kind of focusing on that number versus, it sounds like they're really seeing the work that you're putting into managing your diabetes. And that would be, maybe kind of a conversation that I would suggest, for anybody, if that's something that really seems like it impacts how you feel about yourself, in any sort of way, or, how you take care of yourself, that's worth talking to somebody about. Even if we're not talking about like a eating disorder, right? Something that is a clinical eating disorder, anything that impacts how we relate to ourselves and care for ourselves is worth talking about and getting support around. Because I mean, you're right, this is a full-time job, and so to have like worries, or just like that dissatisfaction that you're describing, that could carry throughout your day, I mean, I think that's worthy of some support.
Mhm. Yeah. Yeah. Yeah.
Thank
Thanks
you.
for sharing. Yeah. I'll just add too. I know I've heard from people I've worked with and others, feel free to chime in, that, um, you know, keeping that diabetes so well managed and doing such a great job with that A1C and time in range can make goals with weight loss really challenging. If you mentioned lots of lows, having to treat lows frequently, or if you're exercising and then you have to eat because you're going low from exercising, so I just want to validate that I know that can be really challenging too with those goals with the diabetes.
My son got diabetes when he was only 20 months old, back in the Stone Age, when the only thing there was urine testing. And then he got a pump. He got one of the first pumps that was available when he was only 9 years old.
Wow.
And we testified in Madison because we lived in Green Bay at the time. And Wisconsin became the first state in the country to mandate coverage for insulin and insulin pumps. It's hard to imagine that before I guess it was 89, people couldn't even get insurance coverage for insulin. I mean, it's just unbelievable.
Oh.
People would die without their insulin. And then, then he grew up and went to college. And CGMs didn't come out till I guess the early 2000s. I'm not sure when the first Dexcom was called the G7. Anyway, in 2001, I became diabetic, which was totally a shock. And I was 58 years old, got type 1. And now it's happening more and more that older people are getting type 1. And so my husband and I, he got diabetes right when Mary Tyler Moore became involved with JDRF in 1974. And JDRF was really much in contrast to the ADA. And so anyway, blood sugar testing started the same time that David got his pump, because you couldn't have a pump unless you could test your blood sugar. So that was 1989, I guess. No, 1980. And so I'm saying all this because of what Liam said about his mother. Now, my son did not have a CGM, but we always tried to encourage him, to take care of his diabetes. And I guess we talked about his A1C. I do not remember that. And now he's a mature man. He's 52 years old. And I'm really aiming this at Liam from what the very heartbreaking things Liam said. My husband and I always felt what we were doing was trying to keep our son healthy. Our whole family was on a low carb diet. Our other son, who didn't have diabetes, had to eat what we all ate, and we never had dessert, and we didn't have, maybe for birthdays, maybe we had a little cake or something, but we thought we were just doing our best to keep our son healthy. And now, as a mature man, he blames us the same way that I hear Liam blaming his mother. And it's very heartbreaking. I mean, we're not the way he described his mother. I mean, I'm not paranoid. I'm not the horrible words he used for his mother. And actually, now that people with children who have a CGM can share their data with somebody like their parent, I can see how that could lead to a parent trying to control their child.
It was surveillance. It was a tool that has saved my life every day. My pump and my CGM.
Right.
A tool that saved my life every day and makes diabetes not a full-time job, but rather a side hustle compared to just doing finger sticks and insulin. She used it like to spy on me.
Right.
And if she thought I ate something that I didn't tell her about, I was getting grounded no matter what, because she was always right. So,
I mean, that's just
one mother to another. Do you think that her maternal instinct was misfiring when she saw my wasting away due to diabetes?
I mean, I can't even imagine. I do not share my CGM data with my husband or with anybody. I don't want anybody to see it. It's just up to me. I mean, my doctor sees it, say, every 6 months. But how old were you when your mother was seeing?
I was in high school. I was diagnosed at 15, and this happened up until I was 18 and moved out.
What kind of CGM did you have? A Dexcom?
It was a Dexcom and an Omnipod, and then as soon as I moved out, I was so traumatized from her spying on me with my diabetes, however, that I went just to basic shots and finger sticks for like 4 years. And only about 6 months ago did I get back on a CGM and a pump, because I worked through the trauma about it.
Yeah, but
because my mindset was like, I can leave no trace with diabetes. She has no evidence against me. She can't tell how often or when I'm using a pump or a pen. Right, she can go into my pump history and see exactly when I'm taking insulin. She can't do that with a pen.
But you're an adult. You're an adult now, aren't you? Over 18?
I am now. I'm 23 now, and I still feel like I need to be secretive and keep this stuff not in the open.
She has no legal right to see any of that.
As a minor, she did, though, Carol.
Yeah, but right now she doesn't. The reason I brought this up is this has been a huge shock to me and my husband, that our son feels the way you feel about your mother. He kind of feels that way about us, even though we didn't have, I mean, in those days, there was no CGM. We just would talk to him about in his A1C, I guess. I mean, I don't even remember doing that. It was so long ago.
See,
But
the thing
he
is, my mom
I mean,
will
he sure
never,
remembers. Yeah, but my son's 52 and you're only in your 20s.
Yeah.
You know, and this goes way back. I mean, imagine being 20 months old and getting diabetes. So, I mean, we're just so grateful that he's pretty healthy and has a life.
It actually speaks to a lot of what, I mean, as a professional, like that I oftentimes hear, and is kind of that evolution too of like what our knowledge is about diabetes management and the role that that food plays and like how we manage that. Because I mean, I think for a very long time, it was very the knowledge and the research was very limited. It was
technology.
The technology was limited. This is good. This is bad. This is what we know does impact things. So we have to do this, right? And as we've expanded that knowledge, is kind of when you know better, you do better kind of stuff. And I think that's a big message that Gina and I also hear and try to spread as well, is that there are these messages that people can get about diabetes management that can, interact with an eating disorder. And the messaging is coming from a place of, we really want to like help. And this is what we know at the time is maybe the best information we have. And that doesn't always translate to what the person needs or like what we learn about things over time and as that changes. And so I think this is such a big point.
Yeah. And especially that time, Carol, I was going to say in the 70s and 80s, we had to, I'm sure you had to restrict those carbs. And, when it was just NPH and R, it was so much more challenging. Where now with the newer pumps, I think people can have the option to have a lot more flexibility. So yeah, it sounds like you were doing what like you said, exactly what you needed to do at that time and trying to keep your son healthy. Mm-hmm. Yeah. Amanda, anything else? Otherwise, I can just kind of wrap up with a couple thoughts and slides that I have about ways to think about relationship with food and body and insulin. Does that sound good, Amanda?
Absolutely.
See. Yeah. So, and this is kind of coming from Amanda and I as, professionals in this space. So would love to hear your thoughts. Feel free to chime in of, I'm going to talk about how we can promote a positive relationship with insulin, with food and with our bodies. So please chime in. I think one thing when we're talking about insulin, I will hear people tell me that, hey, to them, insulin equals fat. And just, how just not true that is, right? Insulin is a tool for fuel. It allows us to take in our nutrition, right? It's just a hormone that allows us to use our food. And one thing to think about too is if somebody is, perhaps lost a lot of weight when they were newly diagnosed and then gained some of that weight back, framing that as a sign of their body healing. Again, you having that hormone again and getting their nutrition again. And then I would say less insulin is not always better. I don't know if everyone would necessarily agree with that. I think this can be pretty nuanced, but I think there is sometimes what I hear from people kind of the stigma that, hey, if you are taking more insulin, you are not doing something right. And certainly there are ways, just from the burden perspective, I understand taking less insulin definitely is nicer, or, having less insulin on board, but just something to think about in the diabetes community of how we might be talking about that to just promote that relationship with insulin use. And then food. I think we all could probably talk about this a long time. But my personal opinion is that, again, different strategies work for everybody. But I think, we can eat carbohydrates and our brain needs carbohydrates when we have diabetes. And so really trying to frame carbohydrates as fuel. And food has no moral value. So trying to talk about carbs, objectively, any food groups objectively not as good or bad can be helpful. And then this next couple bullets here are from, if anyone knows Lauren Plunkett, she's a wonderful dietitian and diabetes educator and lives with type 1. And she shared some things in a presentation for diabetes educators recently. And it's just kind of aligned with exactly what I like to believe and recommend as well. So rather than the messaging of, hey, okay, if you have diabetes, you need to eat low carb, high protein, reframing that instead of as eating more plants and more color. I think, with that recommendation of eating low carb, it could lead to higher saturated fat intake, which can impact cholesterol, or restricting sugar, which then could lead to cravings or overeating sugar or carb and shame. And I also think it's misleading to say that, low carb is the best way to eat, because fruits and vegetables are carbs and whole grains are carbs and are really important for our, gut microbiome, and for our heart. And certainly we know protein can, help stabilize blood sugars, but just that recommendation of high protein could lead to higher intake again of that saturated fat and less fiber overall. So I really think just kind of, again, reframing it as, hey, more fiber, variety, pairing those food groups together. So rather than getting rid of those carbs, what foods can we add to our carbs to help support blood sugars? And you all know this a lot better than me, but just kind of knowing what works for your bolusing, right? If you're including more carbohydrate, can you do earlier pre-bolus or pair it with, higher protein or higher fat foods? It's just some things to think about. Paul, is there any thoughts on this or things that are helpful for people as they've worked with their relationship with food, or thoughts on carbs? Perfect. And I can't see it. I'll just say I can't see the chat since I'm sharing. So feel free to shout out if anyone has something.
I did see something come through my email. This is Trisha.
Oh,
yeah. What was it? Meal sequencing was in the USA Today.
I got that in my email today too. Yes.
Mm-hmm.
Has anyone else heard of that? I have. Yeah.
I haven't heard of that term.
Same. Yeah.
But I've done that with my own food. If I'm a little high, I'll pre-bolus, but I'll also start with my protein, eat my chicken and my broccoli first before my potatoes.
Mm-hmm. Mm-hmm.
Or more. I might take a bite of potatoes here and there, but
yeah. Yeah. So the idea, this term meal sequencing, the same with me, Trisha. First I heard it called that as, eating your higher protein, higher fiber things first and saving the carb for the end. And that's something where I would say, again, it goes into, is that a rule that you can never break, or is it something that just helps you when you're running a little bit high? And so it sounds like the way you described it, Trisha, of like, yeah, if I don't mind, starting with the salad and the meat, having a couple bites of the protein, if I'm running high, like great. But if that's maybe the only way someone can eat, or they're really restricting themselves from those carbs, then that's where it could be more problematic. But certainly, do other people find that helps to sequence it that way?
Yeah, I think of it more as a tool.
Yeah. Mm-hmm. Part of your bolusing strategies. Yep. Yeah. Thanks for sharing that.
Yeah.
Yeah. And then with our bodies, at Melrose, especially, or just in my regular practice as a diabetes educator, I really like to focus more on health promoting behaviors over the number on the scale. And so it doesn't mean that, if someone has a goal for weight loss, or, weight loss would be beneficial for them, that we're not looking at that at all, but it's just looking at, hey, what behaviors might lead to weight loss, but regardless will make someone healthier, both physically and mentally. And so, focusing on, adding in fruits and vegetables, stress management, sleep hygiene, right? You guys know, smoking cessation, those things being the focus rather than that number on the scale, because weight is not a behavior. We can't just decide to go out and say we're going to lose weight, right? We have to look at those behaviors. And that can often shift and give people a more positive relationship with their body. And I think this next part is especially important with diabetes, because like I said, if someone's exercising and always having low blood sugars and then frustrated that they have to eat, we're missing a lot of those other benefits of movement besides just the calorie burning effect. So we're really trying to focus on how movement makes us feel. And you guys probably know a lot of these. These are all just the many, many benefits of activity besides burning calories, and how wonderful that can be. Just things to think about with that. And I'll just end here, just to know, for any of you or for loved ones, things like that, with or without diabetes, this is our patient scheduling line at Melrose. If someone calls this number, if they have diabetes, we have a specific care manager that works with all of our patients with type 1 diabetes. And so we kind of do a phone screen. And then I always say it's no commitment. All you're committing to is a phone call when you call, and you'd be set up for an intake assessment with one of our doctors, where you'd potentially be given a diagnosis of an eating disorder, and then a recommendation for which level of care might be best for you. And we really do a team approach. So we have a medical provider, a therapist like Amanda, a dietitian would be on your team, a psychiatrist if needed. And if you have diabetes, you'd be welcome to work with me as well. So, and I'll just end with, we have a podcast at Melrose. We have a few episodes about diabetes. Episode 31 is one of my favorites. It's someone who lived for many years with an eating disorder and type 1, variety of symptoms, and is living an awesome full life in recovery right now. And a new episode is dropping in July that Amanda and I did on GLP-1s and weight loss medications. So we mentioned diabetes in there for sure, but just kind of GLP-1s in general too. So yeah, I'm gonna stop sharing here. I can see you all. Yeah. Okay. Any other, oh, there we go. Okay. Any other comments or questions for Amanda and I?
Thank you. It was very informational. I appreciate it very much. Thanks so much.
Thanks for letting us join and for your sharing.
Thank you, everyone.
When did you start that podcast? How long ago was that started?
Let's see, Amanda, probably 3 years ago?
Yeah, 3 or 4 years ago. I think there are 60 some episodes total. I think the one that's coming in July will be the 4th one that's specifically on diabetes related issues with eating disorders.
Gotcha.
But helpful if anyone's looking to learn more about eating disorders in general, like separate from the diabetes. There's lots of great content on that.
Yeah. I'm sure the GLP-1 is pretty peculiar and just uprising right now, where you're trying to convince them not to lose too much weight to get osteoporosis or fractures and stuff like that, or they're just getting like super skinny or
Right.
coming off of it.
Right, and I think that's really the crux of things, is that those medications can be, incredibly beneficial for people when they are used for, diabetes management, for people who are, working to get some of their numbers like in range and stuff like that. And we know that if they have a co-occurring eating disorder, that poses the risk of exacerbating it. And so we can't treat them like in a silo, right? We have to think about, if we use this medication, which we know can help with the diabetes, that we could run the risk of it impacting the eating disorder if somebody has that, and just to be thoughtful about how you might want to proceed with that.
Mm-hmm, mm-hmm. Yeah, I see Cynthia wrote in the chat, curious on our thoughts on GLP-1s with type 1. Yeah, so I'll just add to that. I think our recommendation is often just to really go slow with titration and make sure, you're checking in with a provider. And I'm saying you as anyone going on. I know you said not necessarily for you, Cynthia, but checking in with someone with each dose increase. And the highest dose is not always the best dose. You need to be able to still eat and ideally have hunger and fullness signals, especially if you've struggled with your relationship with food. And so I think just really going slow, being aware of side effects and what you can do to manage side effects. There is some research that GLP-1s can help with binging, but they are all very small studies without much follow-up. And so the concern is it just a Band-Aid? Is it, what Amanda and I have seen, is that someone might switch to a different eating disorder symptom besides binging, or they might obsessively gamble or shop instead of binging if they could no longer binge with a GLP-1. So still really important to address that relationship with food, like Amanda said, before going on a GLP-1.